Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by three physicians, Dr. Rebecca Sevier, Dr. Sweta Singh, and Dr. Teresa Jacobs. Dr. Rebecca Sevier is a hospital medicine certified physician serving as medical director of care management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Sevier is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Dr. Teresa Jacobs is a clinical professor of neurology at the University of Michigan and is a distinguished expert in neurocritical care. Her wealth of experience in teaching and research brings invaluable insights to our discussion surrounding a variety of intricate case scenarios. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations. Today we have selected two intriguing cases to discuss. Dr. Rebecca Sevier will kick us off by introducing our first case.
How are both of you doing today?
Good, thank you, Rebecca.
Yeah.
How are you?
Yeah, I'm doing pretty good. So it's good to see you guys again. I know we've got a couple cases to talk about today. I'll start out with mine, and then I know you've got an interesting one to jump to after that, Teresa. So my case is an MA plan case. So just keep that in mind as we're going through this. And it is after January 1st. So this is an 86-year-old patient who had a prior history of CHF, some chronic stage 3 kidney disease, and prostate cancer, who's presenting with some hemoptysis, a couple episodes at home, and had presented to the emergency room. They did their workup, and they found the patient had bilateral lower lobe pneumonia. Labs were not terribly exciting for it, so don't really add a whole lot to that. He did not have any hypoxia. The patient did have a history of AFib, and so was on Eliquis. And so they started the patient out on some Rocephin and zithromycin. The patient on hospital day 2 was still having a small amount of hemoptysis. They did consult pulmonary to evaluate the patient. There was some discussion about maybe needing a bronch, especially if this wasn't improving. But they, opted on hospital day 2. Since the hemoptysis wasn't a large amount, they opted to kind of sit tight on the patient, hold the Eliquis, and monitor in the hospital and continue IV antibiotics. Patient ultimately had a 3 midnight hospital stay. And as you can probably imagine where this is going, we got the denial from our MA plan. So I'm going to pause there and ask both of you, if this case came to you as the PA, what are you thinking in terms of, are you going to appeal it, or, again, general thoughts on this case?
Can I ask you a couple of questions, Rebecca?
Sure.
Like you said, the second day they were continuing IV antibiotics, broad spectrum, but no hypoxia. The only thing you had is a chest x-ray finding. And you also said the hemoptysis had continued in pulmonary medicine, was waiting to see if bronchoscopy would be something they'd want to do based on what was happening. So you said that was the second hospital day. What happened over the second midnight?
The patient, did okay that next, midnight. They, didn't develop, the hemoptysis, only went through hospital day 2. and did not, hospital day 3, they did not, have any more episodes. They were still holding the Eliquis. That day, they have to then monitor him for a third midnight, but they did continue the antibiotics. He did not have any new hypoxia, but did have, like I said, 3 midnights of hospital care.
Did they restart his Eliquis then, Rebecca?
I think they did it on, I don't think they did it on hospital day 3, as I recall. I think they were going to, resume that after discharge, and just give him a little bit more time to recover from his pneumonia.
I think the other follow-up questions I would have is, because I can see how this can be sometimes difficult to discuss. Was there leukocytosis? Was there anything else to say add to that pneumonia, the severity, either with leukocytosis, because there was no hypoxia, right, throughout the stay?
No.
Was there
fever, anything else?
Any C-reactive protein, ESR, elevated inflammatory markers, or procalcitonin that you know of, Rebecca?
I don't remember on the calcitonin if they checked one or not. I mean, the labs, were not like, he had some chronic stage 3 kidney disease. So I think creatinine, 1 and change, but not, like markedly elevated, pretty much in line with his baseline chronic kidney disease. Did have CHF, but did not have a overt exacerbation. Discontinued on maintenance meds during the hospital stay.
And just one other question. Did they think the hemoptysis was in any way related to the chest x-ray findings? I know when we think of aspiration, we usually think of right-sided findings on a chest x-ray, but was there any concern that the hemoptysis and the bleeding could have led to an aspiration event?
I didn't see them talking about, an aspiration mechanism as their concern. I think they did think, pulmonary thought that the hemoptysis was related to the pneumonia. Certainly they were contemplating, if this wasn't getting better, doing that bronchoscopy, making sure there wasn't, mass or something else other than just that inflammation causing that, airway, irritation and some bleeding. It wasn't massive hemoptysis, but definitely it still was hemoptysis, and it did continue into hospital day 2 on a patient with Eliquis.
I was just worried if it was more not in the lungs, and if it were upper airway or oropharynx in origin in some way, if it weren't clearly hemoptysis, if there were any arguments that could be made in that direction. So to give you my perspective on this, I would have called it inpatient. We have a patient who has a need for anticoagulation, who's being taken off of anticoagulation because of concern for bleeding. We have an abnormal chest x-ray. We have the use of broad spectrum antibiotics for over 2 midnights. We have pending decisions being made by a consultant service regarding the need for further testing. So I would have thought, in summary, from my point of view, that your 2 midnights would have been met for medical necessity, and I would have called it an inpatient based on that.
I totally agree, and I would have done the same. Although I can see how why we are discussing this case, because these get a lot of gray and weak, and a lot of time pairs would try stick to, and I can even start imagining what will their counter argument, which I'm sure we'll be sharing soon. But agree, I wouldn't just call it ops at this point, because there was definitely need, medical necessity, and like Teresa beautifully summarized, all the things that the patient has, and especially with that Eliquis, which increases the risk of bleed and potential morbidity, mortality risk with that, and need for an urgent bronchoscopy. So it's not you're just another community-acquired pneumonia patient that's coming in. So because of all that, I would agree and also recommend inpatient.
Okay. Yeah. And that's exactly where my head was going on this particular case. I thought it had decent merit. So I thought this, when my team was sharing it with me, I thought, that should get overturned. I didn't think it was a questionable medical necessity for that second midnight. And even, you start calculating the PSI, given this guy's age, kidney disease, heart failure, cancer history, it does put him in, to a PSI, class 4. So it does make him, higher risk. It also, this is a interqual payer, and patient had, there's a whole category of like frailty diagnosis. And so he actually met interqual for inpatient. Like it wasn't, it wasn't even, I even had that going, but unfortunately, we had a situation where the paramedical director didn't see it that way. Her argument for not overturning it was that the patient wasn't hypoxic, and we just were not able to get the medical director to move beyond that. Like that was the thing that the patient didn't have, that they felt the patient had to have in order to make the medical necessity there. So so one of the things I wanted to bring up with this case is that, and I've been trying, with my own team since January, really been trying to get a feel for how our payers interpreting the 2-midnight rule. And my general assessment is a lot of our payers are really, I think there's a learning curve, the 2-midnight rule. All of us who've been, dealing with traditional Medicare since 2014, we've had time to get used to it. We've had time to talk to the QIO, read all the bulletins, listen to, lots of education on it. And so I think it feels more natural to us. So I do think early on, there's definitely a learning curve for our payer medical directors. But what I'm finding is most of them are following it. Like I can have, I feel like the majority of our MA plan medical directors that my team deals with, this would get overturned. But what I'm finding is just isolated medical directors with all of our payers that will still stick to, criteria or something. Like they just, you can't move them past, and they have a really hard time understanding the concept of medical necessity at second midnight. So so mentioning
but
all
you
of
said
that.
It met interqual criteria, correct, Rebecca?
It did, but for this particular medical director, we were just, that was, I don't know, they had to have hypoxia. That was just it, and that they were not going to budge past it. So given that, the general pattern of most of our medical directors, you present a reasonable argument like we laid out here that shows that medical necessity, but you aren't getting them to budge. What would you guys do with that? Like having just framed that, you guys have both been in leadership position for your teams. Like what are some of your ideas for how you would handle this? Because to me, this is feels like an outlier to me. And so I'm just trying to get your perspective on where you might go, with this type of situation.
Do you want me to go, Teresa, first?
Well, it's fine. I would go back to the medical director, and I would maybe ask some questions myself of them and their understanding of the case, which is, what if this were hemoptysis, but we didn't actually know where the blood was coming from? And what about the complication of the anticoagulation? Is there ever a time? I would just try to phrase questions that would get them to think about the fact that there's more at play here than simply hypoxia going on. And it's unfortunate. It sounds like they needed to have another coffee in their day, because they were really a little bit uptight if they were focused simply on that, when you've got so many things going on here. Elevated risk because of underlying conditions. You've got the hemoptysis. It's witnessed, obviously. You've got pulmonary medicine involved. You've got broad spectrum antibiotics. It's just like you have so many things listed there. I think I would go back through to each of those things and say, well, if this patient didn't have anticoagulation, would that have made a difference? Or get them to start to think about and then, given the atrial fibrillation, given the kidney disease, do you not think that portends potentially a high risk for this patient? And if not, could you qualify that for me? I think sometimes trying to turn it back to them well, first of all, she or he has their mind made up. They've got their mind made up. Sometimes you can't do anything about that. Like I said, another coffee needed. But trying to focus on each segment of the argument for why, broad spectrum antibiotics that required IV. Would you have given this patient PO antibiotics and discharged them? I would keep asking the questions of the medical director to try to get them to step away from their position and see all the other issues that were involved in the patient's care. I'm not saying I would be successful, but that's how I probably would have approached it.
Yeah, I do agree. Sometimes a little persistence. I've had plenty of conversations over the years where you get an initial no, they're not willing, but you ask a few more questions. You're like, are you really sure? I really feel very strongly this patient meets inpatient. And you kind of phrase your argument a little bit different. And definitely I've found that, sometimes it does get them to start thinking differently and help see it in a different light. So I think that can be a great strategy, especially in the moment of, trying to see if you can turn, that outcome of it. Sweta, you had some other ideas of what you might do with this?
So I've run into those where you can start asking them questions, give them specifics, and outlay the specific risks, and they would listen. But then sometimes I've run into situations, like Teresa said, where they have their mind made. They are like, well, but between day 2 and day 3, did anything change? So why did we continue with the IV? Why did we not just switch on day 2 and send? And they started asking those, even though we say we are monitoring, but was there a hemoglobin drop? So I can see all these arguments that's coming back. And like I said previously too, have I run into those? Yes. And I think I'm glad, Rebecca, that you've had good experience with a lot of these MA plan medical director accepting the 2 midnight, because we haven't had that much yet. We still are just, if you go by 2 midnight, are running into a lot of resistance. We have to, a lot of our patients end up staying for longer and are able to get an argument on the basis of that. But coming back to, I can see how this can still not be something that pair would agree or would. So in case if the pair comes in and gives an explanation that I agree with, which in this case I don't think we'll agree with, because hypoxia should not be only thing to be looked at. Have I heard that they've stuck to hypoxia? Yes. In those cases, what then we do is, which is next step, appeal those denials if we are not able to have a successful peer-to-peer discussion. Some of the times, or I would say only a couple times, where we've had not a reasonable discussion, where we felt like we're not able to have a communication, we've reached out to the pair's main medical director or their supervisor to just have that conversation. Are we all on the same page? And have that communication to make sure, have that open dialogue, and sometimes even had our physician advisor meet the pair's physician advisor in a virtual meeting to build that relationship. If we are noticing a consistent patterns where we are having a difficult conversation and not a meaningful conversation. So we've taken that approach too.
Yeah, and I think that was, kind of one of my points with this case. And I think, one of the things I'm doing with my team is that we're really trying to understand how are our payers interpreting this? And really seeing what are the patterns, what are across the board for MA plans, and what are the patterns within a given payer. And again, for me, I'm seeing it's really most of the medical directors on any given plan are following it. You can have a very appropriate 2 midnight discussion, just like if I were talking to a QIO medical director, it would flow the same way. We would get the same outcome. But then when I'm finding these outliers, I have found that's really been my next strategy. We do the written appeals, but when I start seeing a pattern, and with the way we document our peer-to-peers, we do put in the medical director name so that we can try to look for these patterns. And so that is, with this particular case, my team started escalating to me and say, hey, we're really having trouble with this one medical director, with this one plan. And, and I was able to actually run my data, pull the cases, and I even did some cases myself just to get a feel for what was going on. And that's exactly where we went with this one. Just in fact, yesterday met with their regional medical director to have a conversation. And I will say, I've done this, multiple times in the past, and I don't do it often, but when I see that pattern of someone that's really just an outlier, maybe oftentimes I'll see it with a newer medical director, and I get it. We've all been there where we didn't know what we didn't know. And so I oftentimes reaching out to that medical director's leader, kind of identifying what maybe their knowledge deficits are, some case examples. I think it's been a really effective method for us to kind of get on the same page and have less conflict, because I hate kicking that can down the road to my written appeal team. It's just such a different type of argument, and sometimes they get stuck. It's hard, once they know a peer-to-peer has been done, oftentimes it's harder for the payer to want to overturn in a written appeal. So I like to be more proactive and just nip it in the bud if I can take care of it with my team. And so that was, I guess, one of my, strategies, and I think has been particularly helpful. So hopefully it'll make some change for this particular medical director, and, we'll see how, how our subsequent cases go. So.
Absolutely.
Well, thank you for the case, Rebecca. We appreciate it. And that's, it's always hard to go above someone's head because, that's always a hard thing to do, but it's good sometimes because it helps you allow them to become educated, and it also sometimes will help you have a reversal of a denial even, which is good.
Yeah, and I think it's just like if someone gave me feedback about my, team, it's always done collaboratively, educational, like we're here to learn and improve. And I think, approaching that with the payer too is how you can be successful with it. It doesn't feel adversarial, on either side. Because I think if you take it, attacking the payer, like that may not go so well. But I think if you approach them collaboratively, you can have some really positive outcomes.
Okay.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. APPLCOM is inclusive of all practice settings. Membership in APPLCOM also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, APPLCOM membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers. Join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acma.org/membership to learn more. Let's continue with our second case.
Again, thanks, Rebecca. Do you think, guys, we should move on to a second case to try to have a second one in this session? And I was going to bring to us today a pediatric case because we don't usually do those. So the case I have for you today is a 6-month-old male. This child has a history of short gut syndrome secondary to malrotation at birth. And he has had a small bowel resection and has only 5 centimeters remaining. He is TPN dependent and has a Broviac catheter in place. He came into the emergency department at noon on his first hospital day, and he was febrile on presentation. He stayed and was admitted because they felt that the differential diagnosis here included a viral illness versus a line infection, and they were worried about the development of sepsis. So the patient came in and was started on cefepime and vancomycin. And the patient really only stayed 48 hours, and the line was removed and replaced. And in laboratory studies, a COVID test was positive, but the patient was not treated separately for COVID. Blood cultures were obtained right on admission, and at 48 hours, there were no growth to date. So the recommendation was to discontinue the antibiotics, which was done. And then the patient was discharged from the hospital on day 3 at about 4:30 in the afternoon. So again, maybe a little bit over 48 hours, but not a lot. And he did not go on to show any more features of sepsis. So this is the case that we have. And my question for you guys is, this this is a level of care question. Would you call this patient an inpatient? If so, why? And if not, why not?
Did the patient meet interqual criteria?
They did initially, yes, because of the fever and the other medical complications and the initiation of broad spectrum antibiotics IV.
And so when I look at this case, I have to remind myself, peds are not little adults. They are different, and we cannot just take them like adult coming in with a fever who can take care of themselves. And two, peds cases, kids tend to recover much faster compared to adult. So commonly they would have shorter length of stay. But one patient came in super sick, had a central line, did meet the interqual. We had to wait for the cultures. We had to continue the IV antibiotics, though we were able to come down, and the final diagnosis was a viral illness, but that too in a COVID in a 6-month-old, not something we knew at the time of admission, and that still needed the intensity of care. I would still argue as an inpatient for this one.
Rebecca, what was your perspective on this case?
Well, I mean, I think if I were seeing the case early, like it came to me hospital day, 1 or 2, before they were, the day of discharge, and someone said, would you keep it inpatient? I'd probably be like, yeah, let's keep it inpatient. I don't know. Maybe this is a line infection, and we don't know where it's going. So I think it's one of those that it wasn't wrong to make it inpatient. But I'll say in my experience, though, this is probably, I don't know if you said or not, either a commercial or Medicaid case, I would say, especially my Medicaid payers that I have to deal with, it's really hard to get anything that's 48 hours or less. Even if they're really sick, they really seem to be stuck on that time base. And I've had some true ICU patients, and they're like, well, they just recovered in an obs period of time. And it's been very hard to move them past that. So I think I would try it as inpatient. I would try the peer-to-peer because I think it has some merit, but I wouldn't be super surprised if I couldn't overturn it. So What did you do with it, Teresa?
Yeah, I agree. And this case it came up recently, so we called it inpatient. And a couple of things here is we have 2 of our PAs who have pediatric specialization. So one of the PAs that's pediatric said, in a short-gut infant with a high risk of malnutrition and dehydration, and the need for the central line to be removed and replaced gives it an extra level of complexity that really need to be taken under consideration. And our other pediatric PA said during a viral illness, it doesn't take a lot for a 6-month-old who is on the edge anyway to be pushed over the edge. So I thought those were both valid points. Mm-hmm. And we did call it inpatient. We're going to wait to see if it gets denied, but I wouldn't be surprised if it got denied either, Rebecca, just as you were saying. And I think all the arguments that Sweta made were made by the adult medicine PA who put in the inpatient designation. So, okay.
Yeah, I think that's where, have I run into those peer-to-peer where pairs stuck to that 48-hour, even if the first 24 hours were in ICU and there was Q1 hour vitals, Q1 hour things happening. Yes, and that we've, and then they keep bringing back like examples of like asthma or DKA where kids recover pretty quick, but they initially need high intensity. But like you said previously, sometimes just explaining the reasoning, being persistent, and sometimes we have to go beyond to the next level.
Yeah. And sometimes what I like to, or have to remind my team or, the UM team is that, our team gets kind of sensitive about those cases. We end up rebilling for outpatient or outpatient with observation. And, I think when I think about a case like this, like, again, I look at the beginning, this was very reasonable to make inpatient, very reasonable for us to try. And if at the end of the day, we don't get it and we end up doing a rebill, like, I'm okay with that. Like, those are the rebills I'm okay with. Now, the ones that came in for a planned cardiac cath, and someone just had inpatient pre-selected in their, post-op orders, and they stay overnight or go home the same day. Like, those are the ones I want to be more worked up about. That's a preventable, inappropriate inpatient. This to me is one I want to be okay with. So I sometimes I get my team like looking at their rebills and like, oh, we should stop doing that. Like, no, I think this kid looks sick. So I think it's okay to start him out as inpatient.
Yeah, thanks, Teresa. This was really an interesting.
Yeah, that's good.
Thank you. All right, guys, I think that does another session for us.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Doctors Severe, Singh, and Jacobs for sharing these interesting cases in this episode. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes. Until next time, this was Care Transitions Today, Case Conversations.